that's how they put in a needle to know what exact category it would fall into or which type of neoplasm. Again, a lot of pictures. As you can see, we are cytomorphologists and we would like to see more pictures. So Hurdle cell, we tend to put it in a separate category. So that's more coming with an edge, a bit of more abundant cytoplasm, and you can appreciate them on that. So you can sometimes have few Hurdle cells. So the DD between benign and malignant, sometimes it's not possible on a cytology. It's quite often based on the nuclear size, nuclear membrane abnormality. And if I am in a dilemma, then of course I tend to do the molecular studies, which itself it's a different talk, which I'm not covering here. So all our thyroid samples are also sent in the HAMS to make a cell block, and where we can subject it for molecular studies. So in dilemma, we also tend to perform that, not in all the cases, especially, and that's how, if you know that my atypical category is almost very, very low and minimal. We tend to put, meaning Hurdle cell, of course, it's clubbed more in the follicular sort of category, but they tend to do a bit more worse. Even if they're smaller lesion, they need to come out, because on follow-up, even if it's a Hurdle cell adenoma, somehow they have potential to come back again, metastasize, and we think that they have a bit of a different sort of biology. So if I start seeing a predominant population of Hurdle cells instead of follicular, I tend to tell that, and the clinicians are aware that they need to take out the lesion and, of course, explain to the patient in that way. So the metaplastic form of follicular cells, and these are the different names. So large polygonal. So what do I need? Of course, abundant cytoplasm, a big round-shaped nuclei with a prominent macronucleoli. So I really would like to see them, and they should compromise. To call something neoplasm in this sort of category, I need to see more than 30% of these cells. If I see less and I see a follicular neoplasm, then I might just say follicular with some Hurdle cell change. Always remember that you can have in the non-neoplastic, like goitres, Hashi, Graves, a Hurdle cell, and that's how that sort of cutoff criteria is very, very important. And then the neoplastic categories are these ones. So in the non-neoplastic, they're still flat, they form that syncytiae, and they're not too much. They're not just that sort of monoclonal population. And you will have other associated features. So look at that, quite big polygonal, abundant cytoplasm. I can't appreciate nucleoli very much in this. So again, more that sort of round oval shape with abundant cytoplasm. And here you can see that I have started showing that sort of macronucleoli. So that's about Hurdle cell lesions. Now we come into the papillary carcinoma category. They have a variable cellularity. Usually they can have a fibrovascular core. They are monolayered or multi-layered, depending. We tend to call that, when you look on the low magnification, they have different shapes of animals like dragons. And also the nuclei are crowded. They, instead of round, now it becomes oval in shape, which is very, very important. We can have palisading and appear in school of fish, many different types. And now when we look into the papillae, the cytology, they have a powdery and fine granular chromatin. This is much appreciated better on PAP. The Giemsa tends to have a streaky or a scratchy chromatin, They tend to have grooves, inclusions. Now, the proportion of grooves to inclusion is, if I see more prominent grooves, inclusions tends to be lesser in number, and vice versa. We can see some of our bodies multinucleate, and they tend to have a thicker colloid. So just showing you like some different shapes, like swan and school of fish, and some bigger clusters, some lesser clusters, as you all can see. A bit abundant cytoplasm, but look at that multinucleation and trying to form pseudo-inclusions. They have now variable size and shapes. That's the inclusion. You all can see grooves, scratchy, and they, instead of round, they have become more elongated or oval in shape. Perhaps a better nuclear variability, as you all can see, multinucleated giant cells, and that's the prominent groove in the background. More and more like this is, so even if they have abundant cytoplasm and they look herdily, always look into the cytomorphological features, because and look at what company it's keeping. So at the extreme, that sort of left, we see scratchy chromatin and prominent grooves, whereas in this, they look a bit herdily. And we know that a Hurdle cell change or Hurdle cell type of papillary carcinoma do exist. That comes this follicular variant of papillary carcinoma. They tend to be cellular. They are loose cohesive, and since they usually do not have that sort of papillary structure, but always look into the nuclear features in the PAP and DQ. And if I have the nuclear features, if they are round and oval, then to me, papillary carcinoma trumps over the follicular neoplasm. So I pay attention on the grooves, inclusion, and that sort of dense colloid and the shape. So the most consistent feature in diagnosis of papillary are that sort of overlapping nuclei, oval-shaped, the powdery chromatin on PAP, the streaky chromatin on GIMSA. So if I have on both, then I'm assured, and clinically it is thought as papillary. So the radiology, papillary is quite distinct. They have a special and a different type of calcification. And so they, on imaging, people, they can really differentiate very well PTC from the rest of the other things. So usually our form says that it is X centimeter lesion, suspicious for PTC. And then we look into the cytology and then assess all these different criteria. So again, more, you can see that sort of inclusion, elongated nuclei, overlapping, some overlapping. Again, more, can you appreciate that sort of scratchy chromatin? So when you scratch with your nails on your skin, that sort of a scratchy bit or a streaky one you see there. More of a pap smear, more overlapping. They are having a bit of prominent nucleoli, but the inclusions are there, and that sort of a tram track or a school of fish sort of appearance. It is very PTC feature. So that stops with all the different neoplasm. I haven't covered up more of the atypical and NIFP category in this session. I have just gone with the basic idea on how I approach from benign to malignant and what criteria I use in my daily practice. So the TRAPS, like false positive, it is that sort of minimal colloid. It really, and that's why reporting in close contact with our clinician is very, very important. If it's a new person and doing thyroid cytology for the first time, and I'm sure that in your practice, it might be done by you guys rather than the radiologist. So That's far more better because you have the patient in front of you, but we have to rely on the different other. But what happens in our sort of practice is a smaller and smaller thyroid lesions are like an incidentallomas are being picked up because they are subjected for PET or scans for a colorectal cancer or a melanoma or something else, and something PET evid pops up in thyroid, which wouldn't be picked up by in any other scenario, but it's picked up and then they want to assess what it could be. So yeah, if minimal colloid, my criteria then wouldn't apply even if it is. So that's a trap, and who does the procedure is very important. The cellular, the hyperplastic one is also very important. In both these aspects, usually the good imaging technique should tell that it is an okay looking nodule and they are not worried, and then you put everything like a jigsaw puzzle in and then give the right diagnosis. Bloody aspirate can make, or air dried can actually enlarge the nuclei, and if the nuclear details are not well preserved, I basically tend to say non-diagnostic rather than over-diagnosis. Undercalling is my way of doing rather than overcalling, and then I might say that reaspirate is suggested if clinically it's a suspicious nodule. Degenerative and atypical changes in follicular, that could be a trap, and this is one, of course, going more in an agus sort of atypical, A-plus sort of category, and a dominant Hurdle cell population. So that is also quite challenging, and you have to put it in the right clinical context. Repair and regenerative, they are very alarming. It almost looks like an FNA put in a post-operative granulation tissue. So that one needs to know. Then macrophages and all, if they are aggregates and become an enlarged nuclei, then it could be, sometimes you can have a papillary hyperplasia, but looking to the nuclear features more properly, you can have an inspissated colloid resembling like a samoma body, and there could be sometimes a calcified samomatous body, and not all of them. So always look into the nuclear details more carefully. A Hurdle cell just in absence of lymphocydia, that could be, but for me, if it is an Hashi, those Hurdle cell changes are very minimal, less than 10%. And I sometimes, of course, as I say, a Hurdle cell lesion shouldn't be missed. So I tend to say that it's a Hurdle cell predominant or Hashi with some Hurdle cell change, and that gives the clinician that, yes, it doesn't look like a neoplasm, but I have looked into it and considered, and so a close follow-up is needed. Hashi with papillary, that is one of the biggest challenging thing, especially those lesions are very tiny and it can be easily missed. And Hashi, I have seen myself fallen into trap. It can have papillary changes. Florid hypoplastic changes, just a monomorphic lymphoid population, lymphoma needs to be considered. And what I find it important is, even on imaging, it's very important that the radiologist knows what is the thyroid and what are lymph nodes. If the lymph nodes are pathological, that's absolutely abnormal, and that should be a high alerting feature that it is a neoplasm rather than a benign lesion, because it's locally advanced disease and one needs to explore what's going wrong with the patient. You can have syncytial fragments, but there is significant nuclear atypia and what it could be. So Hashi, active Hashi is one of the indolent one also. So Hashi needs to be. And so unless it's not worrying, please do not put the needle in a thyroid because it could be creating an angst with the clinician as well as in the patient. So that stops more with the thyroid, my approach, and how do I do it in my daily practice. And I could have put just the usual thyroid, but I thought I'll put some odd one and discuss this case in thyroid cytology. So the case starts as a 55-year-old female, left thyroid nodule and enlarged lymph node. So this was the history provided to me, and it was worrying to the clinician. As you can see in the background, meaning anybody can tell that's malignant. You have a big and small cells, high NC ratio, overlapping. Looks like the background is not very clean. It looks like dotty and granular and a bit dirty background. Let's look at the cells more closely. Look at that humongous big cell. It's single, but it's trying to form a cluster. In Australia, if we see something like this, of course, we think, could it be a melanoma also? Or is it an anaplastic because it's a thyroid we are looking at? But it's trying to form clustering. So melanoma goes down in the list. Maybe it's a poorly bad malignant tumor, which has a discohesive population of cells as well. And of course, I can't see any inclusions or anything like that. So we had the cell block. Cell block we have made. So we had a lot of cells. Just to show you the PAP again, so that sort of clustering, very prominent macronucleoli. As I said, no doubt it's a malignant tumor. It needs to come out, or it needs to be having a further workup. So since we had the cell block, as I said, we always have, we did the stain. So we did TTF1. You can see nicely nuclear positive staining. And we also threw in a napsin. So to our radiologists, it was very odd looking lesion. It was going across the carotid and all the lymph nodes. And so the lymph node pattern did not match a bit with the thyroid primary. It could be like an anaplastic one, but he flagged as it looked odd and did not look like the usual thyroid. And so we threw in few more stains, TTF1 and napsin. As you can see, there is granular positive staining in the cytoplasm. And so we flagged, we also did PAX8, which is negative, and thyroglobulin is just showing some entrapped. Thyroglobulin has usually a bit of background staining. It's not one of the great one. I have moved more into PAX8. The radiologist also did an FNA from the lymph node, and whenever we do it from the lymph node, we send it for thyroglobulin. The needle washout is sent for thyroglobulin level testing, and in this particular case, it was negligible. So just to let you all know, it's one of a good test where we tend to follow up a recurrence of PTCs in a lymph node. So the primaries come out, it was PTC, and then the patient is followed up, not in the bloods as thyroglobulin levels, and the thyroglobulin level rises and the lymph node starts popping up as well. So our clinician usually puts in a needle in the lymph node, sends us for cytology as well as this thyroglobulin needle washout. So if it is a metastatic PTC, the thyroglobulin levels would be more than thousands. In this particular case, as you all can see, it's negligible. So all these things like PAX8 negative, napsin, TTF1 coming up with a bit of no thyroglobulin level, we flagged that it would be a lung metastasis to a thyroid. And then because it was more, the patient came more with the neck swelling and enlargement and was not screened, was later on subjected to screen for lung. And yes, there were lung nodules, and what we did is the lung biomarkers were done in this because it was already a stage 4. disease. So they were looking for biomarkers. So in this particular case, yes, there was an EGFR targetable mutation detected. ALK-ROS were negative, and PDL1 score with the had a high TPS score. So that was an unusual case. I thought I will share with you. These are some of the acknowledgements whom I have worked with. Dr. Ashwati is my registrar, and she was involved with that previous last case. So that's from me. Thank you, and I will be